尊敬的各位专家、各位同道，大
Dear
家好。
distinguished leaders, ladies and gentlemen, hi everyone. Welcome to Best of ESMO 2025, hepatocellular carcinoma. So today we're going to have a discussion about HCC, and it's been supported by Lily China by inviting international speakers. We would like to share with our Chinese participants the highlights of this year's ESMO and also to have a discussion so that our overseas colleagues can have an understanding about the new treatment cancers concepts in liver cancer recently in China. And today we have Professor Armand Vogel and also Professor Thomas Dickens from France.
So, Dr. Duquesne and Dr. Vogel, it's my great honor to chair today's tonight's session. That is for introduce some highlights from ESMO 2025 to many Chinese scholars, and that is expand from Europe and what you are doing and what the world are doing in the field of the hepatocellular carcinoma, and that's expanding the influence of the academia in this area from the world to China, where at the same time we want our Chinese scholars to express what they are doing now and what is their achievement to the world, especially to the ESMO. That communication, such kind of communication is very important for us to pave a way for the future potential collaboration in this area, so we can collaborate together and fight the same cancer. Thank you. 那么下面就有请我们的第一位的讲者。
So now, without further ado, I would like to invite the first speaker of today, Professor Thomas Dickens, to share with us the new insights into first-line immunotherapy for advanced HCC.
And Dr. Dickens, and he will introduce the new insights in the first-line immunotherapy of advanced hepatocellular carcinoma. Dr. Dickens, please.
Thank you for this very kind introduction, Professor Guang. Just let me share my slides. So first, I would like to emphasize the rationale for immunotherapy in HCC. In fact, HCC is the background of HCC is the chronic inflammation related to diverse etiologies such as alcohol misuse or MASLD, HBV, and HCV. But we have very few mutations per tumor, so we have very few tumor-associated antigens. And the liver, as you know, is the organ of immunotolerance in our body. And most of all, we have cirrhosis in which we have a modification of endothelial cells, and this modification induces tumor-associated presentation modification and default. And with that, we have also fibrotic liver that leads to cell traffic modification. So therefore, we need a combination of immunotherapy to induce real efficacy in HCC. The backbone of this immunotherapy is PD-1 or PD-L1 treatment, and we can add anti-VEGF or anti-VEGFR to switch the cold to an hot tumor, or we can add anti-CTLA-4 to increase T-cell priming. Very, very briefly, I will summarize the three standard of care treatment that we have today in France with IMbrave 150, atezolizumab plus bevacizumab versus sorafenib, with a median follow-up of 15 months. and with a significant increase of the median overall survival from 13.4 to 19.2 months. The second standard of care is Himalaya trial with tremelimumab plus durvalumab versus sorafenib. With this trial, we have a median follow-up of 62.5 months, with a significant increase in median overall survival and a very interesting 60 months overall survival. And the last standard of care is coming from Checkmate 90W study with nivolumab plus ipilimumab versus lenvatinib or sorafenib. And it's the only study with the two others that compared with lenvatinib in 95% of the patients in this study, with a significant increase, once again, of the median overall survival. So what's about ESMO 2025? I will just summarize my agenda. So I will speak about advanced stage. Do we have update from the standard of care, STRIDE and nivo-ipi? And do we have new first-line treatment? And the real question is, can we do better than the standard of care? And we have two different type of study with standard of care as TKI and standard of care as bevacizumab. And I will finish with intermediate stage HCC with the leading question of could we replace TACE with systemic treatment? So first, we have update of the standard of care. We have update of Himalaya trial with the global cohort plus the China extension presented at this ESMO edition. With in this figure, you can see the three-year follow-up of combined China extension and global cohort, with very interesting 36 months overall survival rate of 31%. And in this figure, you have the 6-year follow-up of the global cohort, and we can see in this figure that we still have this very long plateau with 17.1% of the patients that are still surviving in the STRIDE group. So to conclude this study, at 3-year follow-up, the pooled analysis of China extension and global cohort provide efficacy versus sorafenib, including improvement in 3-year overall survival and manageable safety. And we have now 6-year follow-up data for this STRIDE regimen. The second update of the second standard of care is nivolumab plus ipilimumab, and this study focused on efficacy in patients with poor prognosis and liver safety in this Checkmate 90W study. In this slide, I summarize some of the poor prognostic group that we made. ECOG PS1 still favoring nivo-ipi, BCLC stage, and microvascular invasion or extrahepatic spread. More interesting to me is these two last poor prognostic groups, AFP more than 400 nanogram per milliliter, and the first results of the subgroup of cirrhotic patients, and I've never seen that in other studies so far. So we have now the proof that even in the subtype the subgroup of cirrhotic patients included in the trials, we have a significant increase of OS with nivo-ipi. To follow, what do we have new first-line treatment, and can we do better than the standard of care? And we have a Chinese study comparing nofazinlimab combined with lenvatinib versus lenvatinib plus placebo. So the standard of care here in this study is lenvatinib. So it's a phase 3 trial with this new anti-PD-1 monoclonal antibody with very promising phase 1b data. This is a randomized trial with 2-to-1 randomization. This study, the inclusion and criteria are the same than many others, and the primary endpoint was overall survival. The baseline characteristics in this study is that we are expecting it's an Asian study, so 95% of the patients are from Asia, 85% are male, and the main etiology is HBV. We have 14 to 15% of stage B, BCLC stage B, and 95% of stage C. And here are the main results is the overall survival, and unfortunately there is no benefit of this new anti-PD-1 treatment plus lenvatinib versus lenvatinib alone, underlying the huge effect of lenvatinib alone that we can see in other trials. There is here is the subgroup analysis and the secondary endpoint, and very surprisingly, no complete response in this study, with 33% of partial responders with the combination and only 18 with lenvatinib alone. And the progression-free survival is significantly higher with the combination, with a median of 9.2 months compared to 6.9 months. The side effects are what we expect to have, with 55% of grade 3-4 side effect with the combination and 47 with lenvatinib alone. So to conclude, and it was not the conclusion of the author of this trial, but I think that this is a negative trial, despite an overall survival trend favoring the new combination, but it's currently a negative trial. And yes, it could be stated that there is a clinically meaningful improvement of objective response rate and a PFS with this new combination, with a good safety profile of this combination. But the standard of care and the comparator in this trial is lenvatinib, and lenvatinib is no more the first-line treatment of HCC. Can we do better with new treatments when we considered as a standard of care atezo-bev? We have two very interesting studies. The first one is a French study, Prodige 81, with atezo-bev plus ipilimumab. This is a phase 2-3 trial with a primary endpoint of objective response, and the phase 2 was non-comparative. So it was an expected objective response rate more or equal to 35% in arm A and not compared, excuse me, to and arm B is atezobev alone. They include 113 patients in each arm. Arm A with EP 1 mg, and atezobev. And as you can see here, objective response rate is only 30%, so it doesn't reach the level of 35 that was needed to say that this phase 2 is positive and to continue in a phase 3. For secondary endpoint, we have progression-free survival that is absolutely not different in this study, and overall survival that are also very similar between arm A and arm B, even if these data are not yet mature for overall survival. In terms of safety, adding ipilimumab to atezobev increased significantly treatment-related adverse event, and mostly grade 5 adverse event with 6 deaths related to the treatment in this study. So to conclude, this triplet HCC study did not meet the primary endpoint with similar efficacy between both arms, with better tolerance of arm B, atezobev. So adding ipilimumab with the dose of 1 mg per kg is not enough to increase the results of atezobev. The second very interesting study is IMbrave 152 or Skyscraper 14 phase 3 study with tiragolumab plus atezobev versus atezobev. TIGIT, as you know, is a co-inhibitory receptor on activated T cells. And tiragolumab is an anti-TIGIT monoclonal antibody. And we have had previous phase 1b2 Morpheus study suggesting that adding tiragolumab to atezobev could lead to a significant increase of objective response rate. So it leads to this phase 3 double-blind placebo-controlled randomized global study randomizing 669 patients with a ratio of 1:1 with primary endpoint as investigator PFS per RECIST 1.1 and overall survival. This is a global study, interestingly including probably for the first time African patients, and so more global than previous study, with, as you can see here, BCLC-B stage patient around 20% of the cases, VP4 status in 10% of the cases, and AFP more than 400 nanogram per milliliter in 37% of the cases. The main results in this figure, very disappointing, very similar survival curve between the two groups, with 9.2 months of progression-free survival for atezobev alone, and 9.3 for tirago plus atezobev. No subgroup analysis that is interesting for me. And in terms of objective response rate, as you can see, we have around 30% of objective response in tirago atezobev versus 26 in atezobev alone. The median duration of response is interesting in both groups, 13 and 15 in each group. The safety profile seems to be good with tiragolumab, with a very low increase of the side effect. But what is interesting in this study is that for the first time, we have atezobev immune-related adverse event that is reported in a study in IMbrave 150 publication. There was no specific sentences on this immune-related side effect. So as you can see with atezobev, at 13% of the patient received corticoids, and the special interest adverse events that are more related to immune-related adverse events are present in almost 20% of the cases in atezobev group. The common adverse events are summarized in this slide, and there is no surprise because it's very similar to atezobev and to what we know currently. So to conclude, the primary endpoint of investigator-related progression-free survival was not met in IMbrave 152, with a median PFS of 8.2 months versus 8.3 months. And to finish, I would like to speak about intermediate stage HCC and to ask the question, could we replace TACE with a systemic treatment? And we have this ABC HCC trial, first reported by Peter Gallet during this ESMO meeting. This is a phase 3B randomized multicenter open label trial comparing atezobev versus TACE in intermediate stage HCC. So this classical study with randomization 1:1 with stratification according to region, AFP, ALB, and vascular invasion, because vascular invasion was allowed if it's only VP1 and VP2 in this study. The primary endpoint is supposed to allow a fair comparison between two modalities, systemic treatment and local regional treatment. And to allow this fair comparison, the author decided to use time to failure of treatment strategy. So it's a classical criteria, but what is very surprising in this study is that the strategy failure is considered for arm A as a radiologic progression, and in arm B as radiologic progression or stable disease. And stable disease is not considered as a treatment strategy failure in atezobev treatment. And this is very surprising, and It's why I put a fair as with a question mark, because I don't think that it's very fair to compare two arms with two different criteria, because stable disease, nobody knows that is a failure or not a failure with TACE. So whatever, so these data are very immature because it's an academic trial and there is delay to complete the data. But as you can see, we have in this study 74% of the patient with BCLC-B stage and 16% with BCLC-A stage of their HCC. And the treatment, the time to treatment failure is significantly increased with atezo-bev compared to TACE alone. But once again, with different primary criteria to judge this failure of treatment strategy. So to conclude this presentation, this is the first interim analysis with currently a significant difference, but I think we really have to wait for overall survival because in that case, the criteria will be the same in both groups. So to conclude this first part of the talk, there is unfortunately no big news into first-line immunotherapy for advanced HCC. We have confirmation of long-term effect of STRIDE regimen. We have data on efficacy of NIFO-EP even in poor prognostic group. And we have new anti-PD-1 treatment added to lenvatinib that do better than lenvatinib alone. But lenvatinib is no more the standard of care in first-line treatment, at least in my country. And in terms of triplet strategy in frontline, it doesn't seem to be a good option with in these two studies more toxicity and no more efficacy. And to me, systemic treatment in intermediate stage is still questionable after this ESMO 2025 meeting. Thank you for your attention.
Thank you, Dr. Dickens. That's a wonderful talk. And yeah, in fact, you have given us a lot of very useful informations. Indeed, it's no very successful, very big news, but we have known there is a long-term effect of STRIDE, and also some level API efficacy is in the poor prognosis group, and also some other studies, such as triplet strategy seems not working, and systemic therapy combined with TACE is moving on. So that's is a very valuable and summary and introduction to our Chinese doctors. Thanks very much for your very valuable presentation. Thank you, Dr. Kim.
Thank you.
And also, it's our great honor to move to the next speaker, Dr. Emmett Vogel. And Dr. Vogel, great to see you. And Dr. Vogel, Professor Vogel is head of GI Cancer Center of the Center for Personalized Medicine and Medical School Hanover and Germany. And also he has a lot of position in the world at many very famous world leading associations against the cancer and GI cancer. And he will give us, and tonight, he will give us another talk about optimizing strategy for later line immunotherapy in advanced hepatocellular carcinoma. Dr. Vogel, Please.
Yes, thank you very much, Dr. Wing Kwang. Good to see you again. It was a great pleasure. So it's my pleasure to discuss with you the data from ESMO with a focus on later lines. First, here my disclosures. And of course, I mean, when we are talking about best of ESMO, I need to show the ESMO clinical practice guideline and what Thomas has shown before. I mean, I think we have really made a lot of progress. We have a lot of options for systemic therapies, and we are seeing that the systemic therapies are moving to earlier stages. I share Thomas' concerns about the comparison and the endpoints from the ABC HCC study, and I also wonder whether it's a really truly fair comparison. And I think we need to see more data and more mature data to really understand what is the benefit of systemic therapies in earlier lines. Nevertheless, I think it's a very important study. Of course, it helps us to define how to select patients in intermediate stage. And I emphasize that because we also have now 3 or maybe even 4 positive phase 2-3 studies for the combination of TACE plus immunotherapy-based combinations. We know that they are all positive in terms of PFS, but what we have just recently learned, they are most likely all of them are negative for overall survival benefit, which brings us in a really difficult situation where we have a lot of positive trials, but we do not see an overall survival benefit, which kind of raises the question, do we really need to combine? And I think for that, it's really important to get a more granular understanding on the patient's characteristic in intermediate stage. And why I'm saying that? Because I'm convinced that we are using systemic therapies in earlier lines, and therefore it is really important to get a better understanding of what should we do after first-line systemic therapies. And I could imagine that in the future we will have more and more patients that will receive sequential lines of therapy. At the moment, as you know, it's only around 50%, but I think if we are moving earlier, I think this may also increase as we have seen it in other tumor types. And with that, most likely we will improve overall survival. This is a kind of a summary of what Thomas has shown before. We have all these drugs. We can, but we also have to make decisions in first line and decide how we best select our patients. And I think one of the problems we have is that we do have options, which is good. We can apply sequential therapies, but we do not really have good biomarkers to select our patients for one or the other treatment. This is true in first line. We can do this cross-trial comparison, which we should not do, but we are always doing it. And I think we have to do it because we have to select one treatment for our patients. And then when we are moving to second line, it's even worse because many of the drugs we would like and which we will use in second line are without evidence in this setting. So we do have positive data, as you all know, for many years for regorafenib, ramucirumab, and cabozantinib, but all have been tested after sorafenib. And the problem is we do not use sorafenib in 99% of our patients in first line anymore. And I think we have now a practical approach by most international guidelines saying that we should use those drugs or combinations that have positive phase 3 evidence, no matter whether they have been tested in the first line setting, such as lenvatinib and maybe also sorafenib now, or the drugs that have been tested after sorafenib, because we do not think that the efficacy is really kind of modified when we use cabozantinib, for example, after atezobev compared to after sorafenib. But it's academic guessing, and formally, we do not have phase 3 evidence. When we summarize the data for second-line efficacy, you will see we are getting into a dilemma because here it is even maybe more difficult in contrast to first line, where we already see some differences in efficacy. But in second line, it's a very consistent picture we see from the prospective phase 2 and 3 studies, which means we do see usually PFS around 5, maybe sometimes 6 or 7 months, and an overall survival of around 8 to 10 months. This was already true when we looked at the phase 3 studies after sorafenib. Ramucirumab is a little bit an outlier, an antibody, moderate efficacy in the AFP high population. So I'm not really sure whether it has still a big market share today. And I would consider cabozantinib and regorafenib most likely as the more important drug at this point in time in the second line setting. When we now look what data have been published basically for these drugs after atezobev, and again, starting with the drugs that have been originally been tested in first line, such as lenvatinib, and we have a couple of studies from our colleagues in South Korea, you can see again the same picture I've mentioned before: PFS 5 months, overall survival 10 months. The response rate of 14% is a little bit lower than I personally have expected. But on the other hand, in the first line setting, we have seen a response rate of around 20% for lenvatinib, so probably what we can expect. I think the good news is that the majority of patients still kind of get a disease control with a disease control rate of over 80%. So there's obviously efficacy of lenvatinib in second line after atezobev. And when we now look at other studies, and this is basically cabozantinib, these are all kind of small phase 2 studies, around 50 patients, and no surprise, same picture, PFS around 4 months here, and overall survival 10 months. Yeah, so we have a very consistent picture of efficacy data for the different drugs in the second line setting, and it's really hard to pick a winner. And I think it's probably the cumulative amount of data we have for the drugs, and maybe also your personal opinion how you select your patients. And this is a study that we have just recently published at ESMO, the Aurora study, where we looked at the efficacy, very similar to the South Korean study of cabozantinib after here's some slides missing, unfortunately, where we looked at the efficacy of cabozantinib after immunotherapies. Initially, we thought mainly about of atezobev, but as you can see here in the lower part, there were also some patients after lenvatinib and just a few, and after durvalumab. So I think this is at that time the standard of care, what the majority of us use in the second line setting. One important point I would like to highlight is here IB grade. The majority of patients are IB grade 2, and I think this is what we consistently see, that with the when we go from first line to second line, third line, more and more patients are now IB2 and not IB1 anymore, which is important because it's a strong and important prognostic marker, as you know, and median overall survival is definitely shorter in the IB2 cohort compared to the IB1 cohort. Response with cabozantinib, I mean, this is what we have seen in the phase 3 studies. Usually we do not see responses, so we mainly see disease stabilization. So here, accordingly, only one response in our trial, but we did got a decent number with disease stabilization. When we now go to the efficacy endpoint, progression-free survival, 3 months, overall survival, 13 months. So again, it's back in the picture I've mentioned before, probably a little bit depending on the timing of the CT scans, but overall survival very consistently around 1 year in the second line setting. So I think for me, it confirmed the efficacy of cabozantinib, and together with the data from the Celestial study, where also some patients in the third line setting were included, including patients after treatment with atezobev, the Korean study, I think we have a very consistent picture for cabozantinib in the second line setting. Another question we may want to address is whether we can also use immunotherapy after, and I apologize that here, I hope you can see it here, whether we can use immunotherapy in the second-line setting. And we also again see after in the second-line setting, again, the majority of patients has been treated with atezo-bev in the first-line setting. So I think that's always a very important question. So should we continue with, can we continue with tyrosine kinase inhibitors, or should we use and maybe I have to stop staring at them for a second. I think there's one problem here with my slide. Sorry, I'm a little bit confused, as you see. 1 second. Sorry, I need to go to the other presentation. Okay, so sorry, I go back here to the sharing. That was the wrong presentation. I made some updates. Share, okay. Okay, sorry, that was here my confusion about. So this is the right presentation. So sorry, here in the second part, I made a couple of changes. So the question is, how should we best treat after immunotherapy in the first-line setting? And one concept is to continue with immunotherapy beyond progression. And I think we have now a couple of data suggesting that this could be an interesting idea. So this is a retrospective data, a real-world cohort, and you can see here in green are patients that have been treated with immunotherapy beyond progression, and in red, patients that have been switched to tyrosine kinase inhibitors, and in blue, you can see patients that have only received best supportive care. And again, I would like to emphasize what I have said before in the beginning, that still around 50% of our patients get second-line therapy. So now what can we do with this real-world data? I mean, I think there's a signal that at least a subgroup of patients may indeed benefit from immunotherapy beyond progression, beyond use of immunotherapy in the first-line setting, and there may be an advantage over tyrosine kinase inhibitors. So now I think we have to look at the evidence we have for that. And the first study I would like to present here is the question whether we, and here again, I mentioned before, cabozantinib and regorafenib are probably the most interesting drugs from the old phase 3 studies in the second-line setting. Here, patients were treated with regorafenib as monotherapy in the first 2 months, and then there was an early addition of nivolumab. So again, this addresses the question about IO beyond progression. When we now look at the data of patients, so some patients have been treated with atezo-bev in the first-line setting, and I just need to double-check. So in the cohort A were patients that were treated, with sorafenib, and cohort B, patients treated with atezo-bev. So that you can see the majority of patients have been here treated with sorafenib, but also some patients with atezo-bev in the first-line setting. The baseline characteristics are very much in line what we would expect. It's mainly a Caucasian study, a lot of hepatitis C, but also fatty liver disease, what we do see more and more in the West. In terms of Child-Pugh here, very well-selected patients with a very good liver function. So you can see the majority of patients are IB Child-Pugh A5. In terms of side effects, I think it's a side effect profile we would expect. There's nothing really concerning in terms of safety signal, and I think all the data we have seen so far confirm that we can combine checkpoint inhibitors with tyrosine kinase inhibitors, and the side effect profile of the TKIs I think have been proven many times. And when we look at the more details, so what did we observe? I think this is very much in line with the mechanism of action of regorafenib and also the checkpoint inhibitors. A lot of hand-foot skin reaction, of course, GI toxicity, elevated LFTs, sometimes elevated bilirubin. So no surprising signal in this study. when we now look at the efficacy data, you can see the blue line, which are all patients, and then in red, the patient pretreated with sorafenib, and in B, the patients pretreated with atezolizumab. So I think there's already a signal that maybe, and again, numbers are small, but still, I think a decent number of patients. But I think there's a signal that maybe in those patients that have been pre-treated with checkpoint inhibitors, we cannot expect the same efficacy for checkpoint inhibitors in the second line if we treat beyond progression. And I think there's here a trend to a better outcome for those patients that have not received a checkpoint inhibitor in the first line setting. I think the authors conclude correctly that there's a very interesting signal of a median overall survival of 25 months for those treated with Rego plus Nivo after sorafenib, which is certainly interesting. The problem is sorafenib is no longer our first-line treatment. So the question is, what can we really make with this in clinical practice? Then we have now here another phase 1 study, and I think this is a little bit the trend we are observing in HCC, that we are trying to add more drugs to our standard of care, and this is a bispecific antibody targeting glypican-3 and CD3, which I personally think is very interesting because we do see glypican-3 more and more as an interesting target for different drugs, ADCs, CAR T cells in HCC. This was basically a study to look at primarily at safety in terms of baseline characteristics in the study. Nothing really surprising. Also, I think there's not really a very strong signal of toxicity, but there may be some toxicity associated with this. Specifically, the colleagues reported an occurrence of CRS in around 70% of patients, and they basically also showed nicely that with steroid pre-medication, they were able to reduce the incidence. They also observed some hepatotoxicity. Again, this is something which definitely needs to be figured out in this patient population, and we need to see whether we can really safely administer these drugs in the setting. And again, triplet therapy may be a little bit too much for the majority of our patients. In terms of efficacy signals, I think it's not yet really completely convincing. You can see there's still a couple of patients with progressive disease and not so many really deep responses. So we have to see. I think the author concluded here that it has a manageable safety profile, but it requires pre-medication. The steroid use, hepatotoxicity is definitely something that is of concern in HCC, and we definitely want to avoid that. So I'm not yet completely convinced, and we have to wait and see whether and how we can proceed with drugs like this. Having said that, glypican-3, I think, is definitely a very interesting target. Then again, coming back to the questions, can we combine TKIs and checkpoint inhibitors? And this is a study that has been presented by Anthony El-Khoueiry at ASCO 2024. Again, PFS around 4 months. Here, early readout, median overall survival not reached. Again, I'm not convinced 100% that we do see really a strong signal of synergistic, maybe a little bit additive efficacy when we combine checkpoint inhibitors with tyrosine kinase inhibitors. And the PFS is always in range, what I have mentioned before, for the drugs when we use it as monotherapy. And along this line, this is a study we also have conducted in Germany, the Solaris study, where we basically combined lenvatinib and pembrolizumab, which I think is really an interesting combination, and we have just, Thomas has shown the data for Nivo and lenvatinib, or this tyrosine kinase inhibitor in the first-line setting. So there is a signal of efficacy, but it's always difficult to show superiority. And again, when we look at our data here now, it's a very similar picture. So we combine pembrolizumab and lenvatinib. In terms of baseline characteristics, here we had more patients with IB1 compared to our Solaris study. We observed responses in 12% of cases, which I think is in line with what I have shown you before. Disease control rate, again, over 80%. In terms treatment-related side effects, no significant concern. I think the combination is definitely feasible. But again, when we go back to the efficacy data, same picture, PFS around 5 months, overall survival 10 months. Yeah. So I think, it's the same story all along, all the data I have shown you. We have a very similar efficacy data. Safety seems to be manageable for all the drugs and combinations we are using, but it is really difficult to really see a combination that has really more outstanding or efficacy over any of the other drugs. And what we definitely need are phase 3 data, and I'm really looking forward to the data from the IMbrave 251 study. This is now finally a phase 3 study, which looks at the efficacy of atezolizumab beyond progression. So the control arm will be lenvatinib or sorafenib, and in the experimental arm, we will combine lenva or zora with atezolizumab. I think the majority of colleagues will use lenvatinib, and I think with this phase 3 study, prospective over 500 patients, we will get more definitive data on the efficacy first of lenvatinib and sorafenib in the second-line setting after checkpoint inhibitors, and whether it makes any sense to add atezolizumab in this population. So coming to the end, and this is the conclusion, where are we now? And again, we have the IO-based combinations, which I think we use in the majority of our patients. In the second-line setting, for me, lenvatinib is definitely a preferred choice. Cabozantinib, certainly possible. Sorafenib, I think, is most likely our least effective drug. For oligoprogression, we can consider local therapies. And then if we can really go to third-line setting, we can use any of the other drugs we have not used in the first or second-line setting. So I think this is my final conclusion. We have options. We can sequentially treat our patient. We have no biomarker. We definitely need biomarker. Hopefully, we will get at some point to the that we can use our genetic alterations as target. At the moment, it looks more like Glypican-3 as a target for ADCs, CAR T cells. But maybe at some point, also the genetic alterations like beta-catenin or MYC may become targets of molecular therapies. But I think we are not yet there. There are more interesting data to come targeting FGF pathway in HCC. I think it's a very interesting topic with FGF19 as a marker to select patients for these drugs. And I think there's definitely more to come in the next years. And with that, I'm looking forward to our discussion.
Okay, thank you, Professor Vogel. By the way, if you still remember, this summer we had a face-to-face discussion in Beijing, and I'm very impressed for your insight into the understanding of HCC treatment. Today, I think you just give us a talk about a very tough topic, second-line treatment. Well, actually, I think this will be even more tough in China because in Western countries, your first-line choice are relatively formal, or how to say, most of the patients just choose T+A or lenvatinib. But in China, we have to treat a lot of patients who progressed after a very complicated first-line treatment. So it's very, very challenging. Another thing is sometimes in China, we would consider more how could we use local regional treatment to solve some problem in the progress of the first-line treatment. But anyway, thank you very much. And I think we will definitely have a very good discussion. Maybe you can have rest first, because our first topic is about the first-line treatment, which brought us by Thomas. And thank you, Professor Dickens. I think the first-line treatment, you just give us a very, very good summary about what we can learn from the progression from ESMO 2025. And basically, we confirm the efficacy of our standard first-line treatment. We haven't seen very convinced data that if to bring more and more treatment together is a good idea. And also ABC HCC trial is a very, very interesting trial. Although we have only 1/3 information, but I think it actually drew more conversation, more discussion in China. Very, very interesting. Okay, actually we have 4 very prominent experts in HCC treatment in China who will give us a very good discussion about what they think about the 2 talks. And I think we will focus on the first talk about the first-line treatment. Our first guest is Professor Jia Weidong. Then I will switch to Chinese. So
Professor Jia, I think we know him very well. He's from First African Hospital of the USTC. He's also renowned expert of the HCC in China. So we will start with the first topic. So we'll focus on the first-line treatment. So I think you already know the topics. So the topic 1 and topic 2 are associated with the first-line treatment. So maybe Professor Jia, you can share with us your insights. Thank you, Professor Zhao, for your kind introduction. I also want to thank Professor Dickinson for the wonderful talk. For topic 1 and topic 2, I also want to share with you my personal understandings. At the same time, I also have some questions for Professor Dickinson. So we know that Checkmate 9DW, as well as the Himalaya study, have given us the solid foundations for the immunotherapy in the treatment of the advanced stage HCC. However, for the 2 regimens, they have different dosing regimens. And for Checkmate, the Nivo way AP, actually AP regimen will be done 4 cycles, and then to the maintenance work for Himalaya study, development in combination with the tislelizumab. Actually, they use the single dose as the initiation dose, namely the STRIDE regimen. And also Professor Qi, and also namely as like the Leiguan regimen. And actually, for the 2 studies, they reflect the different strategies to prime the immune system. I mean, for STRIDE regimen, in this year's ESMO, we have the sharing of the results. The 6-year OS is 17.1%, and so indicating that the reduction of the AP exposure can have a balance between the safety and toxicity. And for Checkmate 9DW, they explored the higher frequency of dose to overcome the resistance, especially for the CTLA-4 resistance. So I think for dual IO in the field of the advanced stage treatment in the future, we need a better screening of the beneficiary patients. And also, at the same time, we should also pay attention to the frequency of the dosing, and also to pay attention to the microenvironment in the tumor, and also try to identify the biomarkers. So I have a question for Professor Dickinson. In clinical practices, how can we use the tumor biology of the patient, like the immune phenotype and invasiveness, to have the individualized regimen or dosing plan for individualized patient? And for dual IO, dual immunotherapy, the resistance mechanism, is there any difference between the dual IO resistance and the mono IO resistance? If there is the resistance difference, Shall we adjust the sequential treatment strategy?
I think Thomas has got the questions. So would you please?
That's a very difficult question, very interesting question. And if I want to be very quick, we have no answer. And we have no scientific answer to answer to that. And it's a shame because we are using very clever drugs. Immunotherapy is really, for me, the clever drugs, anti-cancer drugs that we have since a century. But we use them as dummy guys without patient selection. Probably because so far the trials were conducted by pharmaceutical industry, and now we have clearly to focus as academics on trials with the main focus on the strategy of the treatment. What is the best? Starting with atezobev and then second line with durvalumab or nivo-ipi. Starting with nivo-ipi or durvalumab, nobody knows currently. And for the question of the regimen of tremelimumab compared to ipilimumab, remember that in Himalaya, there was not in Himalaya, but in study 22, there was a group with 4 injections of tremelimumab, and this group had worse results than a single injection with high dose. Why? Nobody knows. We don't have the data of anti-drug antibodies against these drugs. So maybe there is an increase of ADA with 4 injection of tremelimumab. Really, we don't know. So far, in our multidisciplinary tumor board, we are doing equally all the standard of care regimens because we don't have any scientific proof to choose one or another, except if the patient presents absolute contraindication to bevacizumab or absolute contraindication to the dual IO. But it's very few patients in my experience. I don't know if you have the same experience, Arndt.
Yes.
Okay, please, Mr. Vogel.
I fully agree. I mean, that's definitely something we need to consider. And yeah, I think, I mean, what I also mentioned in my talk, right? We need to have biomarkers to select our patients, right? Where we have so many options, and yeah, that's key for the future. And yeah, and the other thing is about synergy and additive efficacy, right? So we always thought that when we combine drugs, we get synergy, but I think it's not yet proven. And even for atezobev, it's not proven. Thomas, you mentioned it in your talk that maybe we make cold tumors to hot tumors, right? But is it really that we have synergy, or is it that we have additive effect and some patients really benefit from the VEGF component and some from the immunotherapy component, and it's actually a mixed bag of patients that are responding to the combination, right? So I think it's still I think we still need a lot of things to clarify here.
Yeah, I totally agree. And what we could see with the past results, remember the first trial with nivo alone, we had 14% of objective responders.
Yes.
So why starting with nivo-ipi for all patients? Why we don't start with nivo, obtaining 14 to 15% of objective responder, and then in the non-responder adding EP, and then in the non-responder adding bevacizumab, and so on and so forth. So in spite of triplets, a step-up strategy adding one treatment to another if the patient is non-responder. And a non-responder, for non-responder, I include the stable disease patients, because for me, stable disease is not a response to the treatment that, or not what we expect. We expect at least a partial response according to mRECIST criteria.
Yes.
Okay, since we came to another ontology, sequential or combination. Will combination always be a good choice? I don't think so. So I think we have to keep open. Very good answers, and it's very, very, how to say, instructive for us. OK，贾教授，您是不是得到了希望的答案？
Professor Jia, I hope that your questions get answered. And about the second discussion topic, for InBrave 158 and InBrave 152 and also triplet study, they have all demonstrated for the on top of Elizabeth, if we add the third therapy, for example, if we add ipilimumab, etc., it seems that it did not significantly increase the efficacy. However, adding a third therapy actually increased the toxicity. So based on these two studies, I think if we simply just add, for example, 1 + 1 + 1, may not necessarily be better than more precise selection. So in the future, I think we need to focus on exploring the immune therapy combination and also the actual mechanisms of pathogenesis instead of just adding more therapies. We need to focus on biomarker guided treatment. So my question to Professor Dickens is, the failure of triplet therapy, does this mean that the immunotherapy for HCC has already had the ceiling effect? And in the future, what should be our future direction? For example, bispecific antibody and also immunotherapies, what do you think will be the future? Thank you.
Another tough question.
Yeah, very tough. Predicting the future is not what we are the best to do. But as we already have said, we have to focus more on markers, and we have to get some predictors of efficacy. Not only in the tumor, probably it's a mistake from the previous trial to focus the study on what is going on in the tumor. Don't forget that we have an inflammatory disease in the surrounding liver, and the number of immune cells are 3 to 10 times higher in the surrounding liver than in the liver. So we have to, when we biopsy an HCC, we really have to biopsy the surrounding liver and to study if in this surrounding liver we have biomarkers predicting the efficacy of the treatments. So I think we really have to go in this direction, and we have to keep in mind that our patients are very fragile with cirrhosis. And it's completely different to treat cirrhotic patient and non-cirrhotic patient. And it's what I remember in my introduction, cirrhosis lead to a defect of immune presentation and immune cell traffic and so on and so forth. So we really have to take that into our mind. So it's probably different to treat HBV non-cirrhotic patient and Western cirrhotic patient.
Okay, thanks. That's very good questions and answers. Thank you all. And we still have two very famous domestic Chinese doctors. Let me introduce them. 夏峰教授来自于重庆西南医院
Professor Xia Feng from Southwest Hospital to AMU. I think we have heard a lot of discussion. You must have a lot you want to share. So about the two talks today, any comments or any questions? Professor Xia, please.
Pleasure to attend this online meeting. I have it's with the very famous professors in the just now I listened to a lot information about the first line, second line therapy for the HCC. I think it's actually a comprehensive problem. Just now we mentioned a lot of reasons for the effect of the immunotherapy. In my opinion, I think maybe etiology is also very important. For example, in China, we more than 80% HCC patient is due to the hepatitis B. As you know, in the Chinese the group, we maybe have better effect for the immunotherapy. But now we know that some HCC patient, based on the method or the alcoholic reason, the effect of the immunotherapy is not very good. So I think we have to do a lot of research about the etiology, between the relations between the etiology and the effect of the immunotherapy. Just now we have very interesting thinking about if we just to perform the systemic therapy in the first line or second line, but it's often limited effect. But if we combined with the local therapy, for example, we use the TACE or radiofrequency ablation or radiation, maybe with two kind of road, the combination maybe have gained more benefit for therapy. So I have this question: do you think that if we combine the systemic and local therapy for the HCC patient, maybe we can achieve the more benefit?
Very good point. We have now three phase 2-3 randomized trial showing that yes, adding TACE and immunotherapy increase at least PFS. But do we really increase overall survival? So far, the answer is no. So is it worth to try the combination with at intermediate stage? So far, I would say no, because I don't know what are the consequences of this first line IO before the advanced stage. So I don't know if I start to treat my patient with durvalumab plus bevacizumab, for instance, with TACE. Do the patient continue to have the same response to atezobev or stride regimen if it progressed on TACE? Really, so far we don't know. So it's too early, I think, to be sure. But at the advanced stage, it's a good option for sure to add local regional treatment, probably to increase tumor-associated antigen release and presentation to immune cells. But we need clinical trial to prove that that is really beneficial.
So if I can add here, so I fully agree with Thomas. I think but I think it's also now even more important to decide what is the intent of our treatment. Yeah, and I think we are hitting somewhat a wall when we combine everything, right? So we are not really improving more with our overall survival if we just add something, let it be a third drug, or a local therapy. We are ending up around whatever, 2 somewhat years median overall survival. But I think in intermediate stage, and I would also say in advanced stage, when we specifically talk about these liver-limited patients with vascular infiltration, and I think when we bring more patients to potentially curative treatments, I think that could make a big impact, right? I mean, Talenthope was one of the study in this setting showing that if you start with systemic and then select patients with that, there may be a benefit for adding surgery or local ablation. Yeah. And I think personally also transplant in this regard. I mean, we have all these organ problems, but I think when we have somebody in intermediate stage, and when we combine, we're getting great response rates, right? With Camrevo TACE, 65%, we can really shrink these tumors, and then maybe we can better bring patients to resection or ablation. And with that, we may get some patients that have really longer overall survival. Yeah. But I agree, if we are talking about pure palliative setting, just improving response and PFS without overall survival, probably, I mean, I agree, it doesn't sound too convincing to combine everything in the beginning. And I think there's still a good rationale to sequentially treat our patients, right? When we think about financial toxicity, additive toxicity to our patients. Yeah, so it comes at a price for sure, these triplets.
OK， 好，夏峰教授，您关于这个一线治疗的这个，是不是
So
还有其他
Professor
需要
Xiafeng,
这个
do you have extra
分
comments?
享一下？
Anything that you want to share with us?
Published a paper in the BMC Cancer recently. I do a study about the HRT combined radiofrequency ablation. The conclusion expressed the combination, the systemic and therapy is benefit more than the use the systemic therapy alone. Especially in the second line therapy, we often use the local therapy to enhance the effect. In China, maybe it's very really we use a lot of combination about the systemic and local therapy. I think you can see a lot of paper from China published in many journals. The combination, the systemic and then local therapy, may be is a future role for some for the existing patients. So the second question about just now, we Professor Ching, he published he gave a presentation in this ESMO meetings about combine the immunotherapy and the BEFA and the chemo. What do you think the triplet therapy is also the future direction?
So sorry, I am not sure whether I understand the question. So the combination of chemotherapy with immunotherapy?
Yes, the triplet is presented by the Professor Ching. He used a combination with immunotherapy and BEFA and chemo.
Chemo. Yeah. So I mean, again, it's in line with what we have discussed before. I think, I mean, in China, you have a special population of patients, as you have highlighted before, right? You have more younger patients, you have more patients with well-preserved liver function, maybe even without cirrhosis, hepatitis B patients mainly. And I think we have all the impression that these hepatitis B patients may respond better to immunotherapy. So I think maybe we are getting to a point where we can or should or need to apply different treatment depending on the ethnicity and the region. I'm not sure whether, I mean, you have in China, you have data for Folfox, right? And if your tumors are more sensitive to immunotherapy, there may be a rationale to combine chemo plus checkpoint inhibitors. I'm not convinced that in Caucasian patients this would also work, right? And I think for the majority of our patients, I would be extremely hesitant to use chemo. I mean, many of them are IB2, right? Impaired liver function, low platelets. And I think from a toxicity point of view, I think it would not feasible in many of my patients, at least.
I fully agree. Yeah.
Okay. Same thing in Professor Vogel and Decain. Same thing in Western countries. They're very, very hesitant to use chemo for the systemic treatment in HCC patients, especially combined chemo with other systemic treatment. While in China, we use HIC, this hepatic artery infusion chemo, and some centers accumulate quite few experience or data. But I think that will be a point where you could get totally different view from the West or from the inside China. Okay, thank you, Miss 夏峰教授。等一会儿可能关于第二个问题，我们还要请您继续发表
So
高
I
见。
think thank you, Professor Xiao Feng.
To our third prestige Professor Zhou Jun from Beijing. I think you've been listening to our discussion for a long time. You will definitely give us a very good your ideas because you've learned a lot from us. Please.
Okay, thanks for your introduction, and nice to meet you, Professor Vogel and Professor Dickens. You gave us very informative and excellent presentation. And I'm a medical oncologist in Beijing Cancer Hospital, and I focus on the liver cancer and the pancreatic cancer and the biliary tract cancer. So I do have some comments to our first line treatment in HCC. In the first question, we compared the 90W and the Himalaya. And first, I think we should know that the big difference between these two trials, I think the first difference we can see there is the control arm. The control arm in 9DW is lenvatinib, almost lenvatinib, but in the Himalaya is sorafenib. And there's a very big gap in these two control arms. So we can see that the Himalaya's control arm's overall survival is only 13 months, but the lenvatinib in 90W, the OS is nearly 20 months. We know that if we compare the lenvatinib and the sorafenib in the same group, of HCC patients, there's no that big gap. So I think that means we can there are other difference in between these two trials. We can see the difference. We can see from the difference between the two control arms. We can see that maybe they enrolled these two trials enrolled different patients. I think the Himalaya trials enrolled more late stage patients or patients with more tumor burden or patients with more treated or more heavily treated patients were enrolled in Himalaya, I think. So that makes the big gap between these two control arms, I think. So when we turn to the experimental arm, we can see that the Himalayas experiment arm only has 16 months overall survival, but the 90W has more than 22 months. I think the 4 dose of CTLA-4's usage is much better than 1 dose, because we know that if we know that the Himalaya has another group, the durvalumab single-used group, it's another experimental group, but it doesn't fit the endpoints. So the durvalumab is not better than the doublet usage, but it's a little better than sorafenib. The single use of durvalumab. So I think that maybe the when we combine the CTLA-4 and the PD-L1 or PD-1, it is better than the single use of durvalumab or nivolumab. But if we can use CTLA-4 more times, we can get a better overall survival benefits. So I don't think the one dose is enough, but I don't think the 4 doses is the final result. Maybe nowadays in China we are trying to find how many times CTLA-4, how many times or how many doses we should use the CTLA-4 agents. So maybe we don't have any acute answer, but I don't think one time is a good choice, because if we compare the Himalayas experiment arm to the lenvatinib, I don't think if the Himalayas control arm is lenvatinib, so I don't think Himalaya will get a positive results. So
No, I think we 100% agree with that. And I think it's interesting that even after so many years, we do not know what is the right dose of CTLA-4, right? So how much anti-CTLA-4 we need to use. And I think in AstraZeneca tried with the 4 doses low dose, then single high dose. BMS did the 4-dose high dose EP, right? But we are still not convinced that it's the right dose, right? And with HCC artimide, I think we will get an additional approach, right? With a bispecific antibody also targeting CTLA-4, which would be consistently CTLA-4 targeting, right? So I fully agree. And I think it's very interesting that we have not yet figured out what would be the best way to target CTLA-4 and HCC.
Yes, I quite agree that nowadays we still don't know how to use CTLA-4.
Yes, yeah.
But I think the high dose is maybe better than the low dose. We can see that in the IBRAM 152, they use the CTLA-4 in the low dose, but this result is poor. So, and actually, I think in many trials, we show that low dose CTLA-4 is patients cannot benefit from low dose CTLA-4 in HCC. Patients with MSI high colorectal cancer may benefit from low dose of CTLA-4, but patients with HCC cannot benefit from the low dose usage. So I think we should use high dose, or I think at least we should use the 2.5 milligram per kilogram. I think at least this is at least I used in clinical practice, but maybe higher dose will do better, or much more doses will do better. We don't know that. So actually in my practice, I use the CTLA-4 as the patients needed. I would like to use 1 dose first, and we can observe the response. And if the patient's response well, so I will stop it and to look at look for 4 cycles or 6 cycles, and we can reuse another dose of CTLA-4. So this is my clinical practice. So actually, I do have some comments about TIGIT. So I don't think TIGIT is a very good target. So nowadays we have so many data and so many trials failed in all types of tumors, all types of such as lung cancer and melanoma. So TIGIT doesn't show any benefits to this all kinds of cancers. So I don't think TIGIT is a good target. So I don't think the triplet, including TIGIT, will be successful in hepatocellular cancer. And nowadays, I know that in China, some investigators, such as Professor Huang Ming and some professors in Shanghai, are still doing the bispecific antibodies, including TIGIT plus PD-1 in the biliary cancer. But I still think that will show no OS benefits. TIGIT is not a good way to doing the triplet treatment, but I still think the CTLA-4 plus bevacizumab plus PD-1 or PD-L1, this kind of combination of treatment, I still think it may be a work in the hepatocellular cancer. Actually, we trying to high dose CTLA-4 plus high dose bevacizumab plus nivolumab. In our clinical practice, I think the overall response rate is better. Maybe we will have more than 40% or nearly 40% overall response rate, but the toxicity is much more. I think if we combine this three antibodies, so we have much more toxicities. So how to use these drugs, I don't have any idea. We just explore it. But I still think this combination of this triplement, I think will be work. And I noticed that Professor Dickens just mentioned a step up strategy. You used one single antibody first, and then two, and then three. But actually in China, we always using a step down. We always use a combination of chemotherapy. You just mentioned the Celox, the chemotherapy plus bevacizumab plus CTLA-4 plus PD-1 first at the first cycle, and maybe after 2 cycles we killed we removed the chemotherapy, and after that we will remove the CTLA-4. So a step down or a step up. I think it maybe these strategies fit different populations. I think so. That is my comments, and I do have a question for the Dr. Dickens and Dr. Virgil. Do you really think the ABC's design is unfair? I think it's fair. The ABC
very
design.
Good questions. A very good question.
I'm
all ears too.
All doctors in China, intervention, the radiographer doctors, they think that it's unfair to taste, but I think it's fair. So why do you think it's unfair? So I want to know your idea. Okay.
Do you want to start?
Yeah, so maybe I can first. So I just mixed the AstraZeneca drug up, so I have to apologize for that. In the Artemide study, they combine, of course, TIGIT plus PD-1, and I was referring to the other drug from AstraZeneca, where they have the CTLA-4 anti-PD-1 bispecific antibody, right? Volrustomig, very difficult to pronounce name. But I mean, just to your further point before, I think this point about targeting CTLA-4 and TIGIT is still a matter of debate. I'm not sure about the bispecifics as well. I don't give up on on TIGIT completely, and I still think we need to wait for HCC Artemide to see the efficacy, right? So let's wait and see, and then we can make the final conclusion, right? And again, I mean, about the design, I think the problem is that if we just do TACE, right, and we consider failure of strategy when we have stable disease in one arm, and in the other arm we ask for progressive disease, I think it's an imbalance, right? And I think it will also, I mean, I think we all agree that we should not continue with TACE if we only have stable disease. We should stop, right? But I'm not sure whether we can call this failure of strategy, because we have a couple of patients that are stable for quite a while after TACE, right? And again, if we call this already a failure, if we do not achieve a response, I think this will be a big bias in terms of what it means for overall survival. And I'm 100% sure there will be no overall survival difference, yeah, because I think as endpoint, I mean, we need to define efficacy somewhat, but I think this group in the TACE arm, it's a combination of those that really have progressive disease and those that may have long-term stable disease, yeah. And I think it's not fair to call this failure of strategy. And in my clinical practice, I have seen many patients that have TACE, have stable disease, but have stable disease for a couple of months. Yeah, and therefore I do not consider this as failure of strategy and a point where we would need to move on to subsequent therapy.
Okay.
I totally
Go on, Thomas.
Yeah, I totally agree. It's for me, it's an unfair comparison. And failure of the strategy here in this trial, it was very easy to take as a primary endpoint the beginning of the second line or the first line systemic treatment, second line for atezo-bev group, and first line systemic treatment for TACE group. In that case, it would have been a very fair comparison because we compared both groups with the same objective. We start systemic treatment after the first treatment. And then I'm pretty sure that there is absolutely no difference. And as you can, I was very fast in this presentation, but the median of treatment for TACE was only 2.
Yeah.
It means that it's primary non-responders to TACE in this trial. But I have plenty of my patients with 5, 6, 10 TACE during their life. And it's not a failure of the strategy. It was a recurrence after 6 months or 12 months of complete or partial response after TACE. So the real failure is, after TACE, for me, the real failure is when you need to start systemic treatment.
Okay, that's actually it's very to my surprise that I had thought that most of Chinese doctors would disagree with it's fair, think it's unfair, and Western doctors would think it's fair, but I got totally different ideas. Well, but it's good, very good discussion. I personally pay a lot of attention to ABC trial as well. And I'm not sure if it's unfair, but I think we have no idea. First, don't worry. Let's just wait and see. OS is designed as the secondary endpoint, but it just takes longer time. We will see the final result. Like Professor Vogel said, you are very certain that there will be no significant differences. We'll see. Just if you check,
maybe one additional point, and also for the study. So the problem is what I see in terms of overall survival. So if we start atezo-bev or systemic really early, the question is, what would we do after failure of atezo-bev? And I think the majority of patients will not go to local therapies, at least not in the West, right? I would assume they will go to second line therapy. And in contrast, those that have started with TACE, as Thomas have said, right? I mean, sometimes they can get repetitive TACE with response, stable disease, but have really months, even years of disease control, right? And I'm a little bit concerned that we may lose basically one line of therapy, and for those patients in intermediate stage, if we start too early, right? I think we should not overuse TACE. I think we all agree on that, right? But completely abandon TACE, I'm not sure whether we are yet there with our systemic therapies.
So TACE would have its contributions, but if we start directly with T+A, when the disease gets progressed, we lose one of our weapons. Okay, I get a point. Actually, personally, I have a lot of questions, but I leave all the time to Professor Zhou. Now we have to turn to our second discussion panel about the second line treatment, which brought us by Vogels. And as I said, it's even more tough choices or more tough topics. Let's turn to Professor, I'm not sure, Professor Jia, are you still online? Yeah, I think Professor Xia is online as well, but both of you...
I have another question. As you know,
okay.
we have
okay.
no decision making how to we have a very standard indication for the immunotherapy combination. So especially for the second line therapy is also very difficult. Recently, we know that the BCLC have an update. They present a new framework named the QS. It's very interesting, and you know, the QS framework give us new ideas about how to do the clinical decision making. We know that the QS framework named include the complexity, uncertainty, subjectivity, and emotion. It's very complicated. So I want to know what is the decision making strategy in Europe nowadays in the first line or second line. So I will ask Professor Vogel.
Okay.
Yeah, so I agree. The cues concept, I think it's something we need to work with, implement it in our maybe clinical practice, and then I think we need to learn whether it really helps us. For me, it is something that, I mean, that summarizes all of our concerns, right? So I think we all agree we do not have definitive data. We need to do cross-trial comparison. We need to extrapolate from first line to second line. So I think, and what has been summarized in the BCLC paper is kind of the summary of our uncertainty, right? To give it a name, more or less, right? And I think now we need to understand whether, when we have some strategies, how we can deal with it, whether we can come to a point where we have more consistency in our decision making. Yeah. So what I see I mean, we have so many settings in HCC where, at least in my tumor boards, one day we decide for treatment A, next week we decide for treatment B, and the other week we decide for treatment C, right? But they all have somewhat the same baseline characteristics, yeah. And sometimes I wonder, why did we decide for A here and B on the other day and C on the third day, right? And I think it is probably good if we have more kind of a framework and consistency in what we are doing, which maybe also will help us to find really treatment sequences that are best. I think if we do our retrospective analysis, sometimes if I look back like 3 years ago, I wonder, why did we decide this way, right? And today we decide that way without having new data. And therefore, I think the QS framework may help us to be a little bit more consistent, and which maybe help us to develop more systematically best treatment sequences, which I think we urgently need since we do not have biomarkers.
Okay. And you know, this year, Dr. Kudo published an editorial in his journal, Liver Cancer. He discussed about how to choose the regimen about the immunotherapy. As you know, is more acknowledged regimen is the HRT and do chemotherapy. But what kind of indication we can use the HRT and the do immunotherapy? So could you give a strategy? As you know, the HRT can achieve a very recently benefit, but the do immunotherapy can achieve a more extended benefit. Is a long tail effect. So what do you think about the strategy of the Kudo's idea?
So are you referring to the question Nivo-Ipi versus Atezo-Bev? Did I understand correctly, or?
The Professor Kudo gave us a strategy at first, because if you want to achieve a long-term over survival, you may try to do chemotherapy, need to do immunotherapy. if you can achieve a benefit for the recent stage, you can use HIT.
HIT is intraarterial?
What do you mean with HIT? Sorry, can you explain what was the
It means
alternative again?
A plus T, A plus T.
Oh, A plus T. Okay, sorry. Yeah. So I personally think Nivo-IPI is extremely interesting, to be honest, right? So we are getting fast responses. We are getting responses of almost 40%. I think it's a highly effective treatment. And in the cross-trial comparison, I think it's a stronger treatment than atezo-bev. Yeah. So and the quality of the responses with pure immunotherapy, I think, is definitely better than the responses we get with combinations without immunotherapy. So with BEV, for example, I think the BEV and TKI responses have not the same quality as pure IO responses. Yeah. So I personally think that Nivo-IPI is a very, very interesting combination, but the concern is the toxicity, right? And this is something we need to learn in clinical practice. Yeah. So I think what Thomas has shown, obviously the combination works in Child-Pugh-B. There's no more toxicity in IB2, but we know that there's this hepatic-related toxicity, and I think we really need to get more real-world data to understand the safety of Nivo-IPI in our daily clinical practice beyond clinical trials. But in terms of outcome and efficacy data, I think it's very interesting, and I'm very happy that we have it as an additional option in HCC.
Okay. Thank you very much.
Okay, thanks, Professor Xia. I think you got your answers. Let's turn to Professor Jia. What do you think about the second-line treatment? Give us some of your comment, okay?
好的，谢谢赵教授的提问。
Thank you very much for your kind question. So for second-line treatment, we have cabozantinib, ramucirumab, as well as the regorafenib. But for those drugs, they are actually based on the studies for patients that progress on sorafenib or progress on systematic chemo. But we all know that in clinical practices, few patients would utilize sorafenib or systematic chemo in first-line setting. In real clinical practices, in the first-line setting, we'll do the IO combination. So that's why in the second-line setting, we have many difficulties because we don't have evidences to support the second-line treatment. We don't have phase 3 randomized trial to guide our regimen choice. In this year, ESMO for Solaris study, namely lenvatinib with pembrolizumab. And so for those studies, I think they may give us some guidance for patients as how to treat the patients that progress on first-line treatment with IO, especially patients that have the TKI resistance, and also for patients that are unsuitable for local treatment. For patients that already utilize the immune checkpoint inhibitors, if they progress in the second-line setting, we nowadays can still use ICI. But I mean, in the second line, whether the ICI will still be impacted by the pure depletion effect from the first-line setting. So I think maybe in the future, we need to have a clear picture of the microenvironment as well as the clone evolution of the patient to optimize the second-line treatment. The other important thing is that when to change the second-line drug, I mean, based on CT and MRI images, we, of course, will make the observations. But if they progress on the first line, and we will switch to the second line for dual IO in clinical practices, including Himalaya and also 9DW regimens, we can also say that for the two studies, actually, the early OS trend is not very magnificent compared with the control arm. After 6 months, the OS curves begin to be separated, meaning that taking Himalaya, for example, the PFS is very short. Once patients progress, prognosis are very poor, and that's why we have the concept that, based on the aforementioned reasons. So after we use dual IO, especially for steroid regimen, every 2 to 3 weeks, we will check the biomarkers like the AFP, including the other related biomarkers. And during the surveillance, if we identify the abnormal elevation of the AFP as well as the PVCA, and so we need to switch to second-line treatment. So I think in the future, maybe before we identify the disease progression, maybe we can also use ctDNA or the immune subset cells to have early identification of the possible progression, and also to have the dynamic surveillance of ctDNA as well as the subgroups of the immune cells to give us earlier warnings, or even to have the progression on the images so that we can have early identification of those early progressors. So I think that's key to the optimized management in the second line. Another important thing is that for patients that progress on first line combo or have very quick progression in the second line, we should also switch to take care of different mechanisms. That's the priority. And if the patient is indicated for local therapy, we can also combine with local therapy like TACE, PIKE, or even have the combination of the Y19 or the external beam irradiation. And so for CERT and external beam radiation have been integrated into the new guidelines as the radical treatment regimen. So they are not only indicated for unresected patients in early stage as the alternative for surgery, they are also suitable for patients that become resistant to TACE, as well as the patients who progress on first-line treatment. So that's the breakthrough in the second-line setting. And this is also my personal understanding about the sequential treatment in the second line.
Professor Jia gave us his thinking about the second-line treatment, which actually we don't have standard answers, but we can talk about that to improve our everyday practice. I think, is Professor Xia, are you still online? Professor Xia, I'm not sure if he's still online.
Okay.
Okay.
I'm
Do you
still
have
online.
any further comment? Do you have any further comment about the second line choices? 关于二线治疗，您还有什么高见？
Yes, as you know, we if you give a first line immunotherapy combination, we just have 30% of patients can achieve objective response. So most of the patients will receive the second or later immunotherapy. So it's very common in China. I think many of my colleagues will give another kind of immunotherapy combination, especially give local therapy. In our center, we often give a TACE or give my center, we do a clinical trial about use radiofrequency therapy. The aim of the IFA is not for the tumor ablation. There's three objectives. One is for the tumor burden reduction. The second is for the antigen presentation. The third reason is for the change the micro environment of the tumor. So this radiofrequency ablation to enhance the effect of the published the paper about two arms. One is combined IFA, one is just immunotherapy alone. They conclude that the combined the systemic therapy and they have a good result than the alone. So I think in future, especially in the second therapy, the local therapy is very important direction in future. As you know, the Professor Kutu gave a strategy. He called that the ABC sandwich strategies have been used in the outside of Japan. So for the second line therapy, I think combined the local therapy may be the very important direction in about the HCC patients.
Okay.
So nowadays, but we also expect to have there's more and more new agents. For example, the epigenetic inhibitor and other new agents may be used in clinical. We can give a good result. So I think it's a very good chance to discussion about the immunotherapy. As you know, we just know we have achieved much more, but we still have a lot of questions and problems about the immunotherapy.
Okay.
China, we have a lot of HCC patients, so we hope we have more chance to have a discussion with the colleagues and especially experts in Europe. Thank you very much.
Okay, that's a very good talk, and I think it's a little bit unfair for the hoster because I have a lot of questions, but we ran out of the time. Both of our guests are leaving, I think, in a couple of minutes, and but we do have a very good evening. At least me, personally, I have very good conversation with our Western partners. I'm not sure if I have time, but I think for the sequential versus combinations, for local regional versus systematic, I think we have a lot of ideas to exchange. And we do learn from each other. And actually, this is the first time that I talk with Thomas, and this is my second time talking to Professor Vogel. I hope we'll have chance to have some communications like this evening. Next time, I do need to leave some time for myself. I do have a lot of questions, but I think we'll have chance. Okay, we have to stop here, although it's really, I hesitate to say that, but I think both of our guests, Professor Vogel and Dickens, will have another meeting appointment, and we have a very good evening. And okay, I'll stop here. Thank you all, and hopefully we'll have a next discussion in the very near future. Okay, thank you everyone. We'll stop here.
Thank you very much.
Thank you very much.